everyone. Welcome to our webinar today, Expand Your Clinical Reach, How to Apply LSVT Treatments Beyond Parkinson's Disease. And we are bringing this topic to you by popular demand. I think everyone knows LSVT very well for treatment of individuals with Parkinson's disease, but there's always this question out here, what if? You could apply it to other diagnoses, and what diagnoses would those be? What applications, what parameters would I use? And we hope that whether you're LSVT certified or a therapy professional that's not yet certified, or maybe you're a person listening that's living with a neurological condition, that the information from this webinar today will be useful to you. So my name is Laura Gousset. I'm going to be one of the presenters today. I'm a physical therapist and one of the LSVT BIG training and certification faculty. And I'm joined by my colleague Heather Hodges, a speech language pathologist and one of the LSVT LOUD training and certification faculty. Just to save time, I won't read through our bios, but they are here for your reference, and you might want to save them in the slides as part of your CEU application process. Just a few standard disclosures that we all go through. Every webinar, we have both financial and non-financial relationships with LSVT Global, including a preference for the LSVT treatment techniques. Heather is a consultant for LSVT Global and receives lecture honorarium. I myself am an employee of LSVT Global and also receive lecture honorarium. A few logistics for this webinar. First of all, right now, all of your microphones are muted so that there's no background noise from all of your different environments. So we don't hear any dogs barking or children or things like that, so you can listen. There will be an opportunity to ask questions at the end of the webinar. It'll be brief. We'd encourage you to type in your questions at any time into the control panel. It might either say questions or chat on your control panel. At the end of the webinar, we'll answer as many of those as we can, but if we can't get to them all, we will answer them via email. So please feel free to use this opportunity to get your questions answered. You may have received an email with a handout for the slides of today's webinar. If you did not, you can click on the Handouts tab in your control panel right now and open that up. You'll see a PDF of the slides, as well as the reference list associated with these slides that we'll be going through today. After the webinar is done, there should be a survey that pops up. Please feel free to complete that survey. It only takes a few minutes, and it really gives us a lot of great information on how the quality of the webinar was, both in terms of technology and content. A little bit of information regarding CEUs if you're a therapist attending today. Our LSVT Global webinars are not pre-approved or ASHA approved or state registered at this time for speech, physical, and occupational therapy professionals, but they can be used for self-reported CEU credit as non-registered or non-pre-approved CEU activity. So if you'd like to report that, please email us at webinars@lsvtglobal.com, and you can request a certificate with all of the elements on it that you need for self-reporting. If you're not sure if your state accepts self-reported CEUs, the best thing to do is to check with your licensing board or read your State Practice Act. If you do wish to claim CEUs, you must attend for the full hour. If you're listening to this webinar later in an on-demand recorded version, you can email webinars@lsvtglobal.com for instructions on how you can claim CEUs for this activity as well. And just one more quick note for therapists that are watching this webinar right now or at a later date. If you're LSVT BIG or LSVT LOUD certified, we did do webinars on the same topic, but with a little bit different spin earlier this week. And you can find those in your LSVT BIG or LSVT LOUD clinician account. These are the learning objectives for today's webinar. We hope by the end you'll be able to explain the rationale for using LSVT LOUD or LSVT BIG in conditions beyond Parkinson's disease, describe 6 non-PD diagnoses in adults and children where you can use these treatments, discuss outcomes of effectiveness as self-rated by LSVT therapists in non-PD conditions, and also outline the process of decision-making when applying LSVT LOUD or LSVT BIG beyond Parkinson's disease. So now let's kick it off and kind of get to the heart of this webinar. If you're a therapist joining us today, it's probably no surprise to you that there are so many people living with neurological disorders. And I know I was a bit surprised when I found this statistic that was all the way back from 2007, that it's estimated up to 1 billion people live globally are living with a neurological disorder. And because of our aging population in part, the need for speech, physical, and occupational therapies is growing as the number of people living with neurological conditions is growing. So as you know, LSVT BIG and LSVT LOUD really focus on Parkinson's disease primarily. However, that's just a drop in the bucket when you look at all of the other neurological conditions that people are living with, like stroke, the different dementias, atypical Parkinsonisms, multiple sclerosis, CP, and Down syndrome. And these are, of course, just a few examples. Certainly, there's many other neurological conditions that impact speech, communication, mobility, and ADLs. So dysarthria is one common sequelae of neurological diagnoses that has a negative impact on communication. And for those of you that are therapists and live in this world of neurological rehabilitation, you know this well. Of course, it can cause decreased intelligibility, so that it makes it difficult for other people to understand what they're trying to say, and that can be really frustrating for the person that is trying to communicate. There's decreased naturalness in conversation, and oftentimes people with dysarthria encounter negative attitudes or discrimination. I myself have had patients that say, you know, people assume that maybe I'm slurring my words because I've been drinking or under the influence, and not recognizing that I have a speech disorder. This also leads to decreased engagement in communication, which really affects a person both socially and emotionally. And that's certainly something that we want to prevent and reverse as therapists. There are a number of non-motor symptoms that are common across the board of many neurological diagnoses. There can be problems with reduced processing time, so it takes them longer to listen and respond, changes in cognition, apathy and depression, and all of these things can impact both their desire and their ability to effectively communicate. And lastly, neurological disorders are inherently complex. It makes them really challenging to treat as a clinician, even as a seasoned clinician, because there's so many different facets impacting communication, including dysarthria, to figure out, you know, really what's the best path to be able to effectively improve this person's ability to communicate. The same can be said of the negative impact of neurological impairments or aging on mobility and ADLs. There can be balance problems that are really challenging and leading to falls or fear of falling and reduced ability to really get around their homes and get around in the community. There's different gait and mobility challenges, of course. They might need to use an assistive device. Maybe they walk slower than they used to be. There can be difficulties with a range of ADLs and IDLs as well. This can lead to fear of falling and falls, and that is can be kind of a downward spiral, causing reduced activity and secondary deconditioning as well. And as physical and occupational therapists, of course, we're looking at how to reverse and improve all of those things. And just like with communication, it's complex. So when a person is presenting with a myriad or a range of symptoms, sometimes it's difficult to determine, boy, how are we going to effectively impact all of those different domains with a given time that we have. So as therapists, what are our treatment options? First and foremost, we should always be thinking about how we're going to improve or restore function in that individual, regardless of their diagnoses. And sometimes that's difficult if it's really a degenerative condition such as ALS. Maybe we can't really improve the underlying pathology itself, and sometimes we can. So it really varies depending on that diagnosis. We always look at promoting the use of residual function, so using compensatory strategies. These could be physical compensatory strategies, but we also think about neural compensation as well. Are there more intact or unaffected parts of the brain or nervous system that we can tap into as kind of a workaround to improve that person's function and ability to participate in daily life. We also try to set up the environment where the person will be successful in communication and function, whatever the environment may be. Maybe it's their home, maybe it's a skilled nursing facility, but it really involves the people around the person as well as part of the environment. And lastly, we incorporate assistive devices for communication and movement. And in a given patient, of course, we might use all of these options simultaneously to maximize their functional abilities and participation in daily life. So with that quick intro, I'm going to turn it over to Beth for a few slides, and we're going to kind of ping pong back and forth throughout this webinar.
Wonderful. Thank you, Laura. So it's a great framework to begin looking at opportunity. There's a plethora of research that's been done on LSVT BIG, LSVT LOUD. And so taking that opportunity of having that research base in looking at patients with Parkinson's disease, it is great to wonder, what if? What if we apply this treatment to other disorders as well? Now, with these therapies, they were developed specifically for people with Parkinson's disease. And the therapies include LSVT LOUD, which focuses on speech therapy, LSVT BIG, which is provided by occupational and or physical therapy colleagues, and these are certified, you need to be specially certified treatments. You have to be a certified therapist in order to deliver this. And for those of you unfamiliar with LSVT, the letters actually stand for the Lee Silverman voice treatment, because initially it was developed as a speech therapy option for those with Parkinson's. And so why did we see this as an opportunity? Well, one reason is because it's an established treatment approach. There's over 30 years of research on the LSVT protocols, those protocols being LSVT BIG and LSVT LOUD. And we have within the Parkinson's population, large randomized control trials, also some smaller research studies. And then when we started applying LSVT protocols to the other populations, we did research as well. And so in those research studies, it's not to say we have the large randomized control trials, the level 1 efficacy that exists for those with Parkinson's, but we have achieved phase 4 research when applying to other populations. And these LSVT protocols focus on restoring residual function in damaged or degenerative conditions. And we also have found that LSVT protocols may help facilitate motor control for communication, gait, activities of daily living in neurodevelopmental diagnoses as well. So we'll get into some of those details here coming up. LSVT LOUD incorporates principles of neuroplasticity, which is to say the intensity, the repetition, the salience, and complexity that has been established in the research on neuroplasticity as being essential components for treatment, for rehabilitation, or habilitation even. They also incorporate motor learning techniques, so blocked, sequential, random practice as well. And there is extrinsic feedback provided via LSVT teaching techniques. And those techniques are model, shape, drive, and stabilize to achieve the voice or the movement that we are aiming to change and promote improvement upon. LSVT protocols promote intrinsic feedback as well, and that's through the use of calibration to help patients sort of reset their internal sensory system, this internal motor programming that must occur across the motor speech system as well as across the body. So if we consider, for example, learned non-use and residual sensory deficits that some patients who are post-stroke may have, or post exacerbation of multiple sclerosis, those are some good examples. And we absolutely must promote generalization so that it's occurring to other activities and not just happening within the treatment room. That generalizability can really be a struggle for therapists working with patients with neurological conditions, where we see patients talk better or move better in the treatment setting, but getting them to carry over what they've learned to function can be really challenging. And so that calibration training with carryover assignments, education, that's used in these protocols can really help to achieve those goals. And there's key concepts of LSVT LOUD and LSVT BIG alike that will apply to a range of neurological disorders. The first of which is target. What are we targeting in treatment? And across LOUD or BIG, we are targeting amplitude. We're targeting increased movement, increased amplitude as the target. In the speech therapy component, we're working on loudness, and in the body component of treatment, we're working on bigger movements. Another key component that is used to apply to the range of neurological disorders is the mode. The mode is going to be intensive and high effort. We truly are exercising and working out our patients every session, every task, and continuing them to have that high effort when they practice at home as well. And then we're also going to calibrate. We need to address barriers to generalization outside of the treatment room. This is true for those with Parkinson's and equally as important at those patients who have other neurological disorders as well. So let's talk a little more about target. When we talk about amplitude as a target, we can see how amplitude affects voice and speech at the top of this slide. When the voice is too quiet, there's relatively little engagement of the motor speech system, so the respiratory, laryngeal, articulatory, as well as even the neurological, the brain activation. When we are increasing the amplitude, though, via loudness, we see on the right side this engagement that occurs across the motor speech system, and the entirety of the systems engages with that increased amplitude. And now we see healthy vocal loudness. We get great respiratory support, laryngeal stabilization, articulators working, increased signals from the speech centers of the brain. And then this will correlate as well to movement too. So when we're increasing amplitude in the body, as shown in the schematic at the bottom of the slide, when we engage that target of big, that amplitude target, that cue for big, and we see how this also has like a spread of effects across the body in the person's posture, gait, stride length, arm swing, and again, it's all healthy amplitude. This single target will trigger activation across the motor systems, the motor speech system, the whole body motor system. So it's really a cool kind of big bang for your buck, if you will. And when we think about amplitude and sort of thinking of this size of control, in LSVT LOUD and LSVT BIG, the target of amplitude is sometimes to learn to control movement versus overriding soft speech and small movement, which this control of movement, this stability can be particularly important for these other diagnoses that we're going to talk about. So when we're training that stability of normal loudness, normal bigness, improving strength, this is the goal for those with ataxic movements, hyperkinetic movements, such as those patients' status post deep brain stimulation surgery, impulsivity, the hyperfunction that may occur in voice, as well as weakness. And let's talk a little specifically about voice as a source. So this is for your reference. I won't go through it point by point, but when we look at the different dysarthria types, from hypokinetic, spastic, ataxic, flaccid, hyperkinetic, and mixed, you can see the example populations, the component of how their voice is affected. And we're really thinking across each of these types of dysarthria, these various example populations, that voice can be a point of entry, that by stabilizing and coordinating voice, we see that nice spread of effects from a couple slides back that occurs across the motor speech system when we target loudness. And so the rationale for each population, you'll see some themes. For some, we're increasing the amplitude of movement. For some, it's improving the control of vocal loudness, and across all, we're really looking at that improvement in vocal quality, that stability in the speech system, and of course, that control. Now, voice as a source is similar to sort of turning up the TV when the TV's too quiet and you can't understand the actors. But we also look at voice as a trigger, and that's because when cued for loudness, an individual, without thinking about it, will naturally take a deeper breath. Their mouth is more open. We see improvements in intonation and articulation with that cue for increasing loudness. It can also reduce rate for some people with a fast speech rate and the naturalness. And so that speech therapist will be shaping and modeling normal loudness with healthy vocal quality. And by doing that, we see that that voice, that cue for loudness, triggers the spread of effects. And so now to discuss the spread of effects of targeting amplitude and body movement, I will send things back over to Laura.
All right. Thank you so much, Heather. So yes, there are many good things that happen when we work on bigness of movement with good quality. Certainly in people with Parkinson's, there's a problem with hypokinesia or movements being too small, and we're really working on creating bigger movements that are more normal. However, through the sheer repetition and design of the exercises and functional practice of working on normal, good quality movements, we often see changes across the whole system that can include changes in their balance, improvements in gait pattern. That could be speed, it could be stride length, arm swing, posture, it could be a number of different gait parameters, functional endurance. Posture, safety, and confidence really go together hand in hand. Oftentimes, independence with mobility and ADLs, and much more. And so it's really exciting to see the potential to improve a person's function across the system like that. But one thing just to know is that when we use the cue loud or when we use the cue big, it doesn't mean that we are training our clients to talk too loud or to shout. And it doesn't mean that we're training them to move around in their daily life with exaggerated movements. What they feel internally could indeed be too loud or too big. They may feel like they're shouting. They may feel internally like they're moving in this really big way if they have a sensory deficit. But we train what is normal movements, and that's really our job as therapists, is to shape normal, healthy voice and normal, healthy movements through our skills as therapists. So that's just one really important point, and there's some references on the slide here that will go into greater detail about that as well. The mode of LSVT LOUD and LSVT BIG is intensive and high effort, and we found that this is important for both healthy and disordered motor systems. And you can read just a wealth of literature on the importance of repetition of practice. Practice things intensively, using high effort in making changes across the motor system. And this also leads to lasting behavioral changes over time. It's applicable, it's true for both adults and children, and it's consistent with principles that drive activity dependent neuroplasticity. So I won't go into detail about these. If you're a therapist joining us, you are probably quite familiar with these principles of neuroplasticity. We already talked a little bit about intensity of practice. If you want to get really good at something, you practice it intensively. You don't practice it just once in a while. You don't practice it with half your heart. You give it your all and you try to be the best that you can be. You work hard at it. Over time, we increase the complexity because we know that drives synaptogenesis and drives skill acquisition as well, to increase that complexity over time. Repetition is really key for motor learning and for making lasting neural changes. And so think about a child learning something. You need thousands and thousands of repetition of movement patterns before that becomes more automatic. Salience means practicing things that are important to a person, things that motivate them. So as therapists, we really need to think hard about this. You know, what are the things that are important to your client, whether they're a child, whether they're a person that is older and maybe has had a stroke or Parkinson's disease, really whatever it is, get to know your client as a person. Timing can be different for each diagnosis. In some cases, such as Parkinson's disease, we say the earlier that you intervene with intensive therapy and exercise, the better. In other cases, it might be at different timing periods of a child's growth, for example. And in some instances, it might not be feasible to start intensive therapy right away, such as in the case of maybe a hemorrhagic stroke. So that can be very different depending on the underlying pathology. Specificity is important for everyone. So think about, am I training tasks that are specific to that patient? You know, am I working on functional activities such as sit to stand transfers if they have difficulty with that? Or am I just doing motor exercises, strengthening exercises in hopes that that will generalize and lead to an improvement in being able to do that task? Specificity can also refer to the specific deficits that we're targeting. In Parkinson's disease, we're specifically targeting the underlying deficits of bradykinesia and hypokinesia through our focus on amplitude. These plasticity principles also apply to children, interestingly, and the article referenced here is a bit older, but still a really great article. So they need an intensive amount of repetition. They need progressive challenge over time with increasing difficulty, just as you maybe are familiar with if you were in sports or learned a musical instrument when you were younger. They have to have motivators and rewards, and it should be internally driven. It shouldn't be something like, hey, do 10 reps of this and you're going to get a sticker. It really should be more the joy that naturally comes with being able to communicate or do something that's important to them. I think of a child I recently heard about. We'll see her case that her functional goal was to be able to get up and down from the floor so that she could play with her dog. And she was able to achieve that goal. And so get to know your client if they're a child to see what is it really that they want to do in regards to mobility, ADLs, or communication. They should be actively participating in it, and for children, the practice must be structured. So in LSVT LOUD and LSVT BIG, this is how our treatments are structured to achieve that goal of an intensive and high effort practice. The LSVT LOUD speech therapy is delivered as a one-on-one intervention. It's not a group treatment. It's delivered 4 consecutive days a week for 4 weeks. So the patient gets 16 sessions in a month that are each an hour long. In addition to that, they have daily homework and daily carryover exercises. So they really get a massive amount of practice within that 1 month of treatment. LSVT BIG was developed from LSVT LOUD, and so after LSVT LOUD was found to be very effective, LSVT BIG was patterned in the same way. So again, it's one-on-one intervention, 4 days a week for 4 weeks, 1-hour sessions with homework and carryover assignments all 30 days of the month. And now Heather's going to talk to you about the last element of treatment called calibration.
Wonderful, thank you. So with calibration, and that calibration really must be achieved in order for generalization to occur, it's really can't be overstated enough that calibration is just as important for other diagnoses as it is for Parkinson's disease. And that is because if a patient is not made comfortable talking in a new way or moving in a new way, then it won't generalize. And so we see that people with neurological conditions have barriers to generalization beyond what exists for patients who don't have neurological involvement. And so I'd like to go through some of the correlates and similarities between Parkinson's disease and then those other conditions that we'll be covering today. So in Parkinson's, we see a sensory mismatch where patients are talking very quiet, but their sensory system tells them that it sounds of normal loudness. They similarly in movement, they feel that they're taking appropriate strides, but in fact, their gait is quite small, their arm swing is small. And so there's this mismatch. Now, in other neurological conditions, we see sensory systems that are disordered. They may not necessarily have a mismatch of input occurring in their sensory system, but perhaps they're perceiving their world differently. Perhaps they're brain injury or the injury post-stroke, etc. Now perhaps they're having issues with proprioception or visual issues that are occurring, etc. In those with Parkinson's, we see issues with internal cueing, and in the other neurological conditions, we see that there are deficits in recognizing the effort that's required for improved movement or speech. We also see, and Laura talked to earlier, that social stigma that occurs for other neurological conditions, and gave that very poignant example of someone with slurred speech or perhaps a changed gait, and other people think, oh, they must be under the influence of something, let's stay away from them. And then in Parkinson's disease, there are subtle neuropsychological changes. And in other neurological conditions, similarly, we see cognitive challenges. So in Parkinson's, they may have slower thinking, slower learning. We definitely see problems in their ability to shift from one cognitive set to another. And so in those other conditions, we can see language deficits also playing a role. We see issues with attention, also with memory. Reasoning can be impacted quite significantly for some, and decision making. So you can see why we really need to recalibrate the system, perhaps for subtly different reasons, but certainly it's true across all neurological diagnoses. Now, with patients, it's very important to link function and the task-specific practice. Personalize these to each client. It is absolutely vital, or else it will not generalize. The example of the patient who wanted to be able to get up and down from the floor, to be able to play with her dog, is a great example of this. It's not just this ambiguous, let's work on getting up and down from the floor. Instead, they draw in and personalize it so that there's a motivator there, and so that when this person goes home and does it and is able to play with their dog, you bet they're instantly motivated, they're going to generalize. And so we're going to incorporate tasks that are meaningful and salient to the person. It enhances motivation. There's also evidence of the impact on neuroplasticity. We are going to link the program, the LSVT BIG, LSVT LOUD, we're going to link that to functional goals. And when we're practicing techniques, we're going to tap into very specifically, what are the patient's hobbies and passions, so that we can work that into treatment and can be used to achieve this self-realization, these aha moments that our patients have when improved communication or improved movement, gait, and ADLs happen. They absolutely are hooked, they are bought in, they are ready to generalize and put in the hard work because we've made it so meaningful. And with this focus on function, the goal of treatment is that these patients will automatically use improved voice and or improved movement in daily living, and that these improvements are going to last over time. And so with these bubbles, we see what I just spoke to was saliency. We're making it meaningful. We're taking functional tasks, functional phrases, things that they see, environments that they move in every day, things that they say every day, and we are incorporating that into every single session. We work on endurance and ability to stay on a specific task through progressive hierarchies in both LSVT protocols. And we take what they do in the treatment room with us and we give them carryover exercises to implement immediately. Starting on day one, we make them achievable, and we can build up that sort of hierarchy of complexity or duration over time as well. And when you take all 4 of these elements and they're occurring in harmony together, we see that the patients really do indeed calibrate. The treatment dosage, so that 4 days a week for 4 weeks, the homework, the carryover, they're not changed. It's not modified when we're delivering the LSVT protocols beyond those individuals with Parkinson's disease. And so we say LSVT is LSVT is LSVT. You don't take parts or pieces of LSVT LOUD or LSVT BIG and apply them beyond Parkinson's disease and call it LSVT. No, instead you do the entire treatment, the entire protocol, or none at all. And the core fundamentals of intensity, complexity, repetition, task specificity, and saliency apply beyond Parkinson's disease. So dosage and how it's delivered are remaining constant regardless of population it is applied to. And we have wonderful research here for your reference on the use of LSVT LOUD and LSVT BIG on other conditions. And you can see from the references here, some of the research comes from our groups, from our labs, and then there are also external labs and other folks that have investigated the application beyond our lab and our groups. Some of these are single subject studies, some are case studies and small group designs. And so you can see here that in black, we have the LSVT LOUD studies, and in blue are the LSVT BIG studies for your reference. And for more specifics about those references, if you visit the blog listed here on the LSVT Global website, here's the specific address, but if you go to our website, lsvtglobal.com, you can find the link for the blog. And in that blog list, there's a tab for research, and so you can look at specific references for application to other disorders, application to pediatrics, so that you can look at those in more depth. And now let's talk about the real world clinical use of LSVT LOUD in non-Parkinson's conditions. So to get into sort of what are people doing globally, we sent out an online survey. It had 13 questions, and it was sent to LSVT LOUD certified speech therapists in 6 different English-speaking countries. And so 248 SLPs were responded, And that was across 6 countries that were included in those responses. 95% of those who responded were professionals and 5% were students. And what we found were that 94% of the respondents reported providing LSVT LOUD to clients with Parkinson's disease. And so not super surprising, since that's sort of where the foundation for LSVT LOUD came from. And then what was interesting was seeing that beyond Parkinson's disease, 75% of the therapists responding reported using this treatment with adults who had non-Parkinson's disease related diagnoses. And 15% of the therapists reported using LSVT LOUD with pediatric populations. And so we have listed in these charts the different movement disorders, other disorders, and then the pediatric disorders where clinicians were responding that they had used the LSVT LOUD protocols for the different types of diagnoses. And then we also asked them how effective they found it to be. So when we combined the effectiveness, where the ratings of very effective or somewhat effective were indicated, you can see some really nice numbers here. And so I want to draw your attention to not only in movement disorders, which can be related, or in some cases, some people think of it as sort of part of the Parkinson's disease umbrella. We see effectiveness ratings between 75% and 88%. In the other diagnoses, we saw really great numbers there too, across stroke, MS when folks are not in an exacerbation, vocal fold paralysis, and even presbyophonia. And then the children, the pediatric application, much lower potential for usage that was reported where clinicians were implementing the protocol with their patients, but when they were, we saw really great effectiveness, particularly in the cerebral palsy and Down syndrome populations. So very interesting real life clinical experience, clinical wisdom from across the globe. So with those numbers in mind from the survey that was provided and gave us insight into the other populations LSVT certified clinicians are using the therapy for, I want to present you with a case on ataxic dysarthria. And so first we see vowel space data. So for those of you unfamiliar with vowel space or need a refresher about vowel space, essentially when the vowels are plotted on a frequency graph, F1 and F2, we expect to see a fairly large vowel triangle. And this indicates that those articulators are meeting their marks within the mouth, and we are going to get distinct vowel sounds. And perceptually, what this will correlate to is nice, intelligible speech, very distinct speech sounds. Pre-therapy, you can see that this, she's a female with ataxic dysarthria, and you can see that the white vowel triangle representing her pre-treatment data is pretty narrow. It's much smaller, much shorter than the other triangle. And so perceptually, let's give a listen to part of a voice sample, and you can listen for those changes in articulation. You can hear sort of the disorder occurring across her speech.
Describe your speech and voice.
When I'm really thinking, but sometimes I can tell when I'm over-modulating or when I'm under-modulating, it's forced at times. It can be breathy, heavy. My voice gets tired, so it's a real effort at times. And I really notice when people say, "What'd you say?" that I'm really inaudible to them.
So she's a bit mumbled, maybe a little slurry at time with her speech. And then Post-therapy, the data of her vowel space shows the pink triangle, which is larger. So we're going to get more distinct sounds. In other words, her articulators are meeting her marks within the oral space. She's really hitting those articulators better. And when we get better articulation, our speech is clearer and easier to hear and understand. It's more intelligible. So here is post-therapy, her audio sample.
What have you noticed?
I've noticed that it's easier for people to understand me while I am talking. I don't get a lot of "what did you say" constantly.
Do you feel like you do any more talking now that you've had this therapy?
Yes, I do much more practicing and not as much nodding.
Great.
I love that statement, that she's really participating more in the conversation and not just sitting there quietly nodding along. So a really nice visual representation as well as auditory representation when you get to hear her voice. And now we'll hear an individual who has had a stroke and has subsequent dysarthria. I'll play you an audio sample of her pre-treatment, and you'll be able to hear her clinician, and then you'll be able to just make out the patient's voice. And what's remarkable here is that the microphone is the same distance from the clinician as it is to the client. So it's not just a matter of, you know, the patient being further away from the recording device. It's actually equal in distance.
That's okay. Go ahead. Mm-hmm. Oh, you have glasses right on the top of your head. Oh, those aren't your reading glasses? That's okay.
I really should remember. Can you see better?
All right, and so you can hear very indistinct, hard to understand and make out what she's saying. Now, as she's in her treatment, she's reading her functional phrases. These are her daily phrases that are meaningful to her. And so you'll be able to, I think, appreciate the difference. And this is before she's even completed the full 4 weeks of therapy.
We're going to do them in Amharic now, too.
Okay.
All right, so look at the piece of paper if you need them. But we're going to start with Ishi Turuno.
Ishi Turuno.
Nice. That was loud. That was sounding really good. When you're loud, it sounds so clear. Everybody's going to be able to hear you and know what you're saying.
Okay.
Mm-hmm. Try it again. Next one, we're going to say Buna Tatalo.
Buna Tatalo.
Nice. That was nice and clear. You have beautiful Amharic. Next one, you're going to do Wuatatalo.
Wuatatalo.
Yes. Nice loud voice. All right, this one's my favorite one. You ready? Anunkasakasalo.
Anunkasakasalo.
Yes. Nice job. Enid.
Enid.
Good. All right, here we go. Up next is Course Anubla.
Course Anubla.
Very nice. And then Mesa Anubla.
Mesa Anubla.
Mm-hmm. You're sounding nice and loud. That is a good loud voice.
Okay.
All right, here we go. Arfalo.
Arfalo.
Perfect. Nice loud voice on that, Maza. Shintibit Hedalo.
Shintibit Hedalo.
Good. Nice loud voice, Maza. Terragina Lesh.
Terragina Lesh.
Yes.
Great. So really getting those consonant sounds, those vowel sounds, much more distinct. She is reading her phrases, and that go through in Amharic, which I believe is an Ethiopian language. And so nice how you can hear, even without knowing that language, probably, that she's really getting those speech sounds, those very distinct, much more intelligible speech. All right, now this is a pediatric example. So he has cerebral palsy, and so it's a condition that's been there since birth. And in keeping with meaningful, exciting, intrinsically motivating activities, this young man is very interested in space. He loves it. And so we get to hear him do a countdown to liftoff. And you'll really be able to appreciate, particularly when he's doing the countdown from 10 all the way down to 1, and then later when he asks for a drink of water.
Hey, no, we don't have to count down.
We don't?
No, look at this. 10, 9, 8, 7, 6, 5. Hold on. Take 4, 3, 2, 1.
Wow, we just blasted off. Can you tell me one thing about Saturn? Because, you know, I forgot everything.
Blue. Blue. I need a little water.
All right, so cute. And you can tell how that extrinsic motivation is really, or intrinsic motivation is really there and established through a motivating activity. All right, and so that's a little preview of our next case study. This is a young patient, female, who has Down syndrome. And so we'll hear her say, I need help, pre-treatment and post-treatment. On the left is the pre-treatment visual data. So we have a waveform at the top, and then we have the energy, the spectra at the bottom. And you can see when she says, I need help, that the waveform is pretty small. It's diminished in size, indicative of that smaller, quieter voice, and less distinct, certainly. And then when you look at the energy in the spectra representation at the bottom, we would expect to see dark bands, lots of dark grays and blacks, and you can tell how there's not a whole lot of energy. What I'm going to do is play this pre-treatment sample a few times because it does go quickly. And then post-treatment, you can visually see that there's going to be quite a difference in this utterance. We see in the waveform bigger green spikes. We see more distinct shaping to it, bigger amplitude. And then in the energy spectra down below, we see a lot more dark. We see that energy represented. And so here is her post-therapy sample.
I need help.
And I'll play that one more time.
I need help.
And so certainly louder, nice voice quality, better articulation. And I think you can also hear a change in rate, how that speed of her saying, I need help, pre-treatment, was naturally slowed down. And this is all without the therapist giving any cues for over-articulate, enunciate, slow down, anything like that. It's all just focused on loud. So really wonderful to see these changes and these nice case studies here. Now I'd like to bring things back to my colleague Laura so she can talk about real life examples of implementing LSVT BIG with patients outside of the diagnosis of Parkinson's disease.
All right, thanks, Heather. Yeah, so we did a very similar survey to LSVT BIG certified clinicians. So this was a few years ago. It was a 13-question online survey that was sent to LSVT BIG certified physical and occupational therapists in 6 different English-speaking countries. And we have 541 therapists who responded and completed the survey. 97% were professionals and 3% were students. And on the next slide, you'll just see a summary of these survey results. So you can see that the top movement disorders that they reported using LSVT BIG with were secondary Parkinsonisms, Lewy body dementia, and progressive supranuclear palsy. And a good amount, 20 to 26% were using them on those populations or had experience using LSVT BIG on those populations. And similar to the LSVT LOUD survey, really high rating of effectiveness subjectively from the therapist's own experience using it on those populations. Some had used it on other disorders, stroke, balance changes related to aging, and multiple sclerosis as well. Again, really high reported efficacy ratings. So on the next slide, just want to give you a little bit of information on some of the very new research that's come out on application of LSVT BIG to stroke. And as you may know, LSVT BIG is somewhat in its infancy, looking at research on use of LSVT BIG with other populations, especially as compared to LSVT LOUD, which has been around for many more years. So we're very, very excited to see this early research, and we really know, we're confident that this is going to expand over the years. So I'm just going to walk you through this really quickly. These studies all focused on individuals with chronic stroke. Most of them had had a stroke many months ago, some many years ago. And so that in itself is quite exciting to think about making improvements in function in individuals that had already gone through all of their intensive rehabilitation already, were living at home, and now have potential for greater gains. The first one was published in 2018 by Profit and colleagues, and it was just a single mixed methods case study using LSVT BIG, and this was delivered by Occupational Therapy. The outcome measure acronyms here might not be familiar to you. The Canadian Occupational Performance Measure is one that's commonly used in stroke and in Parkinson's as well in the field of occupational therapy. And the Wolf Motor Function Test is the WMFT. And you can see in the results that the COPM, the Canadian Occupational Performance Measure, showed improvements for performance and satisfaction. The Wolf Motor Function time decreased by 45%, so which means that they had much improved upper limb use. Also, interestingly, in this individual, his flexor tone in his elbow was reduced. Then in 2019, Metcalf also published a single case experimental design with 2 subjects, looked at people at baseline, during intervention, and post LSVT BIG. You can see that one of the outcome measures chosen was also the COPM. And in these subjects, she found increased performance in both trained and untrained goals. And that was really exciting to think about the generalizability, that there were things that the patients improved in that they never even practiced as part of their therapy protocol. And the most recent one that was published by Profit again was in 2021. This was a waitlist crossover feasibility trial, and there were 5 clients. So some of them were waitlisted and then had the intervention, and then some had the intervention right away. So they were tested at baseline, after 4 weeks, and then after crossover. You can see again, they chose the COPM and the Wolf Motor Function Test along with some others. 4 out of 5 of those rated performance and satisfaction on the COPM higher, and their average task time on the Wolf decreased. So similar findings to what they found in the initial case study. Some of the qualitative ratings were also really, really positive on patients, or just their reports on improved arm use. A lot of them were using their arm more automatically. They were engaging more in bimanual activities like washing their hair with both hands, holding a cup while pouring a glass of water with the other hand. So both subjective and objective outcomes seen there. This next picture that you'll see here is one of the participants in Prophet study, and this is week 1. This gentleman had had a stroke and he had a lot of tone in his right upper extremity. This was his maximum extension of his elbow and his fingers, and you can see at week 3 now he's getting his arm much more fully extended, his elbow and through his wrist and fingers as well. Next slide. So the last example I want to show you is a pediatric case example. This was very new to us, and we just had a webinar on Monday where her therapist really gave a more thorough story than I'll be able to give here on our short webinar. So if you're interested in learning more, be sure to check out that on-demand webinar through your clinician account, and it should also be in the on-demand webinars on the LSVT Global blog. But this little girl had brain cancer for a number of years. It extended into her cerebellum from the 4th ventricle. She had had multiple brain surgeries, 50 doses of target irradiation, and she had, lasting neurological impairments from that. So in the next slide, you'll see why did they choose LSVT BIG. And the therapist had found that through traditional therapies, they were able to get her stronger, restore her range of motion, but she still had lasting impairments related to her functional independence and her gait. She was still reliant on a walker full time. She was limited in her participation in activities that she wanted to do, like getting down the floor and playing with a dog, horseback riding, other things like that. So they talked to the parents. The parents really had high buy-in, and she went through LSVT BIG per protocol. In the next slide, Heather, you can sure try it, but it's her 30-second sit to stand pre-post. But what you can see is how much faster she is. She more than doubled her repetitions in that 30-second sit to stand test. Post is on the right. Okay, great. So these were her objective outcomes. She had a 26% improvement nearly on her 6-minute walk test, and that was actually without using an assistive device at discharge, whereas beforehand in the pre-test, she used her walker. Her BOT2 score improved from the 1st to the 5th percentile. It might not seem like a lot, but for those of you who are pediatric therapists, you know that's a huge amount of gain to be able to achieve in 1 month time. She wasn't able to do single leg stance or tandem stance at all before LSVT BIG, and you could see that she made nice gains there. And most importantly to her, she was able to only have to use her walker for long distances or uneven ground. Otherwise, for normal household mobility, she didn't need to use her walker anymore, and she was able to get down on the floor and play with her dog. And her parents said she even had interest in getting back into horse riding again. So super great. All right, in these last few minutes, we just want to quickly go through decision-making process. You want to know how do you decide, if LSVT can help someone or not. First and foremost, we want to be transparent and say, hey, it's not for everyone, but as a therapist, it can be another tool in your toolbox. Just like always, you really have to use your clinical judgment, talk with the client and family, do testing to make that decision. On the next slide, you can just see a little bit more of the details of how we determine that. We evaluate their diagnosis and rationale for why we would use it. We see if there's any medical contraindications. There are certainly some diagnoses, such as those listed, that might not be a good fit or safe to exercise intensively. But if there is good rationale, then an LSVT certified therapist can evaluate them and do something called stimulatability testing. and they're looking at, can that patient move bigger, talk louder, and with better quality? If it's successful, they can do a 1-week trial treatment and proceed accordingly. After that trial of treatment, you can really have a better knowledge of, can the client understand their instructions? Are they following along? Are they motivated and engaged? Are they doing their homework and carryover? And do you see and hear changes in their voice and in their movement? And usually within that first week, you can definitely already know, is this going to be a treatment that has potential, or do I need to think about plan B at that end of the week? But more than anything, we say give everyone a chance. I know that as an LSVT certified clinician, sometimes I just don't know, even though I have a vast amount of experience. But give people a chance, because oftentimes they surprise you. If the patient comes in and looks like their condition is severe, advanced, or complex, it doesn't mean that they can't improve. In fact, maybe just the thing they need is intensive, repetitive treatment. The outcomes can be really, really impressive and greatly improve their quality of life. And so when in doubt, try it out. That's what I would say. So in summary, today you learned that there's a really good rationale for why we would apply LSVT LOUD or LSVT BIG to conditions beyond disordered speech and movement with Parkinson's disease. There's research evidence for select populations in both LSVT LOUD and LSVT BIG. And next, you can see that the effectiveness as self-rated by therapists who've been treating for a long time has been quite high for the conditions that they reported. We use stimulability testing, a trial treatment, and our clinical judgment expertise to determine if they're appropriate. All right, so that was a little bit of a whirlwind wrap up. If you're a therapist and need to log off and get back to your busy day, we thank you for joining us. And if you have time to fill out the survey, that'd be great. If you want to stay for a few minutes, we're going to answer the questions that have come in. You can answer them, or you can ask them through the question box on your control panel. You can email us at any time at info@lsvtglobal.com if you don't have time to stay for questions today. While you're typing your questions, I'm just going to remind you of a few things on the next slides. So there are upcoming webinars. There's one for PTs and OTs in August on special representatives from USTEP NeuroWalker and Urban Polling are coming to demonstrate how these devices can improve mobility in people with neurological conditions, and that's in a month on Wednesday, August 10th. Again, it's a free webinar. And then in September, we have another special webinar. This one is more intended for people with Parkinson's disease and their caregivers. It's a really good informational overview, like a kind of a quick start guide. What do they need to know about LSVT LOUD and LSVT BIG? All right, so, lastly too, if you're not certified and you're interested in getting certified, here are just some basic information. Go to our website. You can click on that orange button that says Get LSVT Certified. You can take the course online. That's easiest, most convenient. You could attend a virtual live course. And if you're interested in pediatrics, we do have an upcoming LSVT LOUD for Kids course. It's virtual live in October. All right, so with that, I'm going to open it up for questions. So just give me a second to open up all the questions that have come in. So thank you for those. Okay, first one is for you, Heather. Just wondering whether LSVT can be useful or effective on ataxic dysarthria due to TBI.
Wonderful. That's a great question. And so we have seen with ataxic dysarthria, it can be sort of case by case basis. And that is regardless of where the etiology from the ataxia is stemming from. So whether it's TBI, whether they have something like Friedreich's ataxia. So I would use the framework that Laura set out as far as stimulability. I will say that in other populations, sometimes the and the sustained phonation might not be as gorgeously improved as we see with Parkinson's patients on their assessment, but you may start seeing it more in the speech tasks or in some of the other exercises. So I would do some loudness stimulability across the different vocalization, phonation, reading, conversation tasks, and see what you're hearing. It might be that you see or hear something in relation to articulation or voice quality, and you see that little window sort of opening where we're opening the door to improving motor speech communication. Myself, I have applied it to ataxic dysarthria and had great outcomes for this individual. We're actually currently working on some research with Anya Lowett in the UK on applying treatment to those with ataxic dysarthria as well. So the short answer is yes, try it. It can work for some. You may have some patients where it does not work for them. It's not always a one size fits all, so to speak, but using your stimulability, the reassessment after 1 week of treatment, I think will provide a great framework for you.
All right, thanks, Heather. Next question is, when will the recording be available on demand? Great question. I would say just to be safe, since we're going to splice these segments in, let's give it until early next week. And I believe that there may be an email that goes out, but you can also email webinars@lsvtglobal.com if you want to check to see if, when that recording comes out. Okay, Heather, how about this one? What's the value of the treatment being given on 4 consecutive days per week versus 4 days in a given week?
That's a really great question. We see that the 4 consecutive days are really like the gold standard. That's where you're going to get the best outcomes, particularly in those early weeks. So consider that for either protocol, the LOUD or the BIG protocol, we are shaping a new way of moving, a new way of talking. And so let's say I only see a patient for 1 treatment day, and then they have a day off, and then I see them for 3 more treatment days, and then they have 2 days off for the weekend. That's shaping that idea of trying to work on homework and carryover, wanting them to practice at home day 1. It's going to be, and on their days off, it's a little bit more difficult to get that appropriate shaping, to trust that they are safe to do independent practice on their own, on their day off without us, when they've only had a day or 2 of therapy under their belts. For those patients who are more severe, so when I think of severity, I think of course of like voice strain, voice hyperfunction, because I'm a speech therapist, but I know that the same concerns exist for our OTs and PTs that are giving LSVT BIG. So I will be more concerned about safety for those more severe patients. So I want to get in there and intensely 4 days in a row, get the shaping, get the modeling, also work on getting the buy-in for this new way of talking or new way of moving, so that it's going to be much more straightforward to do it in the 4 days consecutively rather than having a gap in the middle of the week. So that's the best standard to provide the framework of LSVT LOUD or LSVT BIG.
All right, thanks. And then the last question, and we'll be done for our webinar today, is what's the best outcome measure for Parkinson's disease? And I would say it really depends on 2 things. 1, your profession type, of course, and 2, the patient's presentation. For physical and occupational therapy, if you are one of those therapy types, there are dozens and dozens of validated outcome measurements for patients with Parkinson's disease. And if you're not certified already in LSVT BIG, when you go through the training course, we'll give recommendations that are kind of best practice recommendations from the APTA on physical therapy outcome measures, and also occupational therapy outcome measures are provided in the course as well. So if you have specific questions about that, certainly email us at info@lsvtglobal.com. And then Heather, do you have any specific outcome measures you use for speech therapy for Parkinson's disease?
Yeah, I would be looking at intelligibility measures. Certainly that's probably the most predominant and most pressing concern for our patients. So those intelligibility measures in quiet as well as in background noise. I'll also be looking at perceptual forms from the patient, but also from their caregiver or their loved one or a friend that's close to them and communicates with them. And so I will be looking at that as well. And then as far as objective data, we do take decibel levels, sound pressure levels for loudness. We measure duration, we measure hertz for changes in pitch because we know monotone voice occurs. So there are objective outcomes as well as more of those protocoled outcomes that might be perceptual or any intelligibility protocol that you may already be using can be appropriate. I generally tend to do more intelligibility measures just based on conversational speech because that's really where the function and the meaningfulness really strike for our patients. So those would be my recommendations from the LSVT LOUD point of view.
All right, thanks. Well, it looks like we got through all the questions, and really appreciate you all staying to hear the answers to those questions as well. Again, if you have additional questions that you think of, email info@lsvtglobal.com, and we'll be sure to send your questions to one of our clinical experts. But I just want to say thank you for joining. I want to say thank you to Heather for giving us your expertise and your great presentation today as well.
My pleasure. It was wonderful to be here, and I thank you as well. I always enjoy learning from the LSVT BIG side of things and presenting with you. So thank you so much, everybody. And thank you also for your patience with the audio and video clips. And we will get the on-demand version spliced in, like Laura explained, with those, because they really are poignant, I think, to hear and see.
See you next month.
Thanks. Bye.
Bye-bye.